Welcome to today's episode of the American Society of Cytopathology podcast. Before I welcome my guest, let me introduce myself. I am Neharika Shrestha, currently a third year resident in the Department of Pathology at Albany Medical Center, Albany, New York. Today, we are diving into the world of basic lung cytopathology. Joining us is Dr. Swikrity Baskota. She is an expert in the field who is currently a faculty of lung, breast, and cytopathology at UC Davis, California. She is also a current chair of the ASCE Bulletin and Cytopath Pod Board. Dr. Baskota, thank you so much for being here.
Thank you, Neharika, for inviting me for recording this podcast. And I'm really delighted to be here discussing about long cytopathology, which is one of the most common sample we see every day. We will try to keep these podcasts as basic as possible so that it will be beneficial for the trainees like you.
Absolutely. It's an honor to have you here, Dr. Baskota. So, in this episode, we are, as she said, going to talk about various aspects of lung and lower respiratory cytology with her. So, without further ado, let's jump right in. So, my first question, Dr. Baskota, to you is what are the most common indications and types for respiratory and lung cytology related sampling?
So, first, let's talk about the most common clinical indications, right? So, it can be done either for a non neoplastic or a neoplastic condition. For a non neoplastic condition, the most common indication are infections or non-neoplastic lesion, whether they are dealing with a restrictive or obstructive lung diseases superimposed by an infection, or as a surveillance protocol after a lung transplant. Usually, the surveillance protocol after a long transplant has both a component of a biopsy as well as the exfoliative cytology samples. Other clinical indications are work up of image or clinically detected mass, or it could be a staging protocol for already diagnosed malignancy of lung. So, talking about the type of samples that we get in the respiratory and lung related sampling, it could be either exfoliative or fine needle aspirations. For exfoliative, we are talking about the sputum or the bronchial specimens, which comprises of bronchial washing, brushing, and the lavage, or it could be the fine needle aspiration biopsies. For the fine needle aspiration biopsies, it can be image guided transbronchial opt in biopsies for lesions which are hidden under the bronchial surface, or if we are targeting the lymph nodes. Other is endobronchial ultrasound guided biopsy, which is helpful for targeting peribronchial, lung, and mediastinal lesions or mediastinal and paratracheal lymph nodes. Or it could be transesophageal ultrasound guided biopsy, usually done for station 8 and 9 lymph node sampling as a staging protocol of a primary lung mass. Or it could be percutaneous, usually CT guided biopsies, or even ultrasound guided for peripherally situated lung lesions.
Wow, I didn't know there are this many indications for sampling like cytology. When we think about it, I just think it's like screening, just the initial screening. Thank you for that. And also, like as a trainee, I always get confused with various types of bronchial samplings. So, could you please tell us what are the key differences between bronchial washings, brushings, and bronchoalveolar lavage?
Of course, this is the question that I always ask my resident or a cytopathology fellow who is rotating with me for the first time, because I think it is important to understand where we are getting the sample to be able to diagnose the disease more effectively. So, bronchial washings are usually yielded by instilling 3 to 10 milliliter of saline wash from the bronchial wall. The real difference between the bronchial washing versus the bronchoalveolar lavage is how far the saline wash is done. For bronchoalveolar lavage, the saline volume might be a little bit more, and it can go as far as a terminal bronchial. Talking about the bronchial brushings are usually targeted to endobronchial mass lesion, so that we can see a exfoliative sample and probably make a diagnosis if we have a cell block associated with it, and we could reflex immunocytochemistry chemical stains in the cell block associated with the bronchial brushings. Bronchoalveolar lavage are usually done when as a surveillance post-long transplant, or patient they are suspecting of infection, or and so on. Similarly, bronchial washing can be done in conjunction with a bronchial brushing when they are suspecting a mass lesion or they are suspecting an infection.
So it's more of based on anatomic location, like how far the wash is done, right?
Yes, that's correct.
Okay, thank you so much. Now, moving on to next question. What are the normal elements that we usually see in respiratory cytology?
So in the images, you can see to the left is the pap stain smear, and to the right is the Diffquick stain smear or Romanowski Best stain. You can see these are ciliated bronchial epithelial cells where the nuclei are round to oval and situated at the base of any cell. And you can appreciate the cilia. If you, in cytology, we deal with a lot of three dimensionality. If sometimes you will only notice the terminal bar when you are looking, but if you go up and down in your microscope, you are able to appreciate these cilia. This is one of the different elements that we might see in the bronchial sampling. The others are the reactive pneumocytes. These are usually clustered together, appears round to oval with a single prominent reactive appearing nucleoli and a frothy cytoplasm. They are often in conjunction with foamy macrophages, which again signifies that it's a deep respiratory sample that we reached up to the lower respiratory tract when we are sampling the lesions. The reactive pneumocytes can be very deceptive and look very atypical, sometimes leading to a challenge and overdiagnosis of a malignancy if we are not being careful. The other cell type that we have to remember always is, I tell this to any trainee who comes to cytopathology rotation, always think about the anatomic sites that you have to go through while you are sampling the lesions. If you are sampling upper respiratory tract or a lower respiratory tract, you have to go through the oropharynx. So it is very common to see squamous cells, candidal spores, inflammatory cells associated with it. And first thing, if they are not atypical, if they look really bland, first thing to think about is the oropharyngeal contaminants. Like I mentioned earlier, alveolar macrophages is another main component of any respiratory sampling. They usually have a vacuolated, bubbly cytoplasm, often associated with the pigment as we inhale the pigment that are stored in the alveolar macrophages. You can see in these images beautiful alveolar macrophages listed in both the PAP as well as in the Diffquick. You can see in the periphery, these are the vacuolated cells with very bland appearing nucleoli, often without known nucleoli, and even if there is a nucleoli, it is very small, inconspicuous. We also see a lot of non-cellular elements in the respiratory cytology samples. Like in the first image on the top to the left is the Kurtzman spirals, which are associated with eosinophilia or allergic conditions. And to the bottom of the same image, you can see the charcot-laden crystals, again seen in association with eosinophilia or allergic condition. And you're seeing a ferruginous bodies in the upper right side, and it's a corpora amylicia in the bottom right. These are other various non-cellular elements that you see.
Beautiful pictures on those slides. Yeah, the reactive pneumocytes can always be confusing with the malignant cells. Yeah.
Yeah.
So, moving on to our next question is, how do you determine the adequacy for respiratory samplings?
So, yeah, this is another questions. There is no hard and fast criteria of how many of these are required, but it is not the bronchial epithelial cells. Neither it are the non-cellular elements or the inflammatory cells. The presence or the absence of alveolar macrophages is what we are looking at for the assessment of the adequacy. The more alveolar macrophages you see, the better you feel that you got deep and a good lower respiratory tract samples. And you will see more alveolar macrophages post lung transplant or if a patient is a chronic smoker.
Oh, okay. But again, how do you determine the adequacy of long mass FNAs or touch imprints for core biopsies?
So that is always a challenge. Okay, especially when we are doing a rapid on-site evaluation, for instance, in cases of touch imprint or you have only a smear. If there
Mhm.
is a mass in question, if you're seeing highly atypical cells or the lesional cells that could explain the mass, that might be one condition when you call adequacy. But remember, now we are in that area where getting an adequate sampling just to make a diagnosis is not enough. We need to
Mhm.
have enough sample to be saved for future ancillary studies, whether that is a flow cytometry, fish, or molecular studies. So my approach to having a lesional cells, if I see any atypical lymphoid cells, I tell them, hey, I see some atypical lymphoid cells. It wouldn't hurt if we can add one additional sample and send it for a dedicated RPMI for flow cytometry. Similarly, if we see all necrosis, it could be anything. It could be infection with a necrotizing granulomata versus it could be a highly malignant neoplasm with abundant necrosis. I tell them, hey, I see only necrosis.
Mhm.
Is it possible to give me some viable tissue? And I do not call it adequate until I see lesional cells, whatever that may pertain. If I see a granulomata, I tell them, hey, I see granulomata. So maybe we're dealing with a necrotizing granulomatous process. Or any other findings. Sometimes you will see ball of aspergillus in the rapid on-site evaluation or even in touch imprint. So it could be anything that explains the mass lesion.
Oh, okay. Yeah. And also, like, during my cytopathology rotation, I'm always confused. Like, what are the key cytologic features to notice while looking for infections, especially in bronchial lung cytology samples?
Exactly. This is a very huge and a broad topic, and often helpful for the clinician because the microbial studies, especially the culture studies or the immunostains, everything takes a while to come back. So even if we can hint what we are seeing, it helps a lot for the clinicians to come to a diagnosis. So I will be talking about a few infective conditions here. The first one is strongyloids. If you see any parasites here, you can see wind up use a worm with serrated at one end, as pointed by the arrow. Other could be fungal organisms, especially if the patient is immunocompromised or is under an antiretroviral therapy or has a diagnosis of retrovirus infection, or is a post-transplant and you are seeing these frothy, vacuolated bodies, then you might have to think of pneumocystis jirovecii pneumonia. Reflexing a GMS stain is very helpful in diagnosis of PZP. You can see GMS highlights the trophozoites in the PZP. There is even a PZP immunostain, which I used to do in my prior practice, which is also very helpful. But I like to see both the GMS and the immunohistochemical stains. Another most common associated with necrotizing lesion is cryptococcus, where you can see halo of a various size budding fungi associated with abundant necrosis, as you can see in these images. Uh, Other various clinically significant infection is either aspergillus, in which you will see fungal hyphae with 90 degree of branching branching fungi, or it could be mucor, where you see a more broad based branching. And but whenever like these are just morphologic impression. You don't You still need to have a microbial culture studies to really be confident and say, hey, this is this. So I usually try to tell them, hey, I am seeing acute angle branching fungi, and I suspect suggestive of aspergillus species, but the final diagnosis would be made based on serological or microbial culture studies, since these could be critical diagnosis, especially if the aspergillus is associated with tissue invasion lesion, or if it is a mucormycosis in a immunocompromised patient, I usually treat it as a critical value. I try to contact the clinician in the team. So as a trainee, if you see this or if you identify this, even when you are screening the sample before you take it up to the attending, it's a good habit to prioritize these cases. Or if the cytotech alerted you, it's a good habit to prioritize and these cases, look at it by yourself, form an impression, and go sit with the attending to try to evaluate if you can come up with mutual understanding of whether you want to call it aspergillus or leave it as vague, or want to confirm mucor if the patient doesn't have any serological studies sent. Sometimes I tell them, or even a molecular culture, I tell them, hey, I see rare fungal organisms. I'm really suspicious for aspergillus. I was wondering if you can send serology or even microbial culture studies if it is easily accessible. That's how I approach these cases. Another candidiasis, it can be a contaminant, or it can be creating, giving symptoms, especially in patient with in immunocompromised condition. Candidal antigen sometimes may be elevated in bronchial lavage fluid, which suggests true infection than the colonization. Again, we report what we see, right? So I usually say fungal hyphae suggestive of candidiasis is noted. Correlation with microbial culture studies is suggested. That is how I approach these cases. But I do not disregard them. Just saying, just because they are candidiasis, because there are some clinically infectious candidial species as well. Another thing to keep in mind are the granulomas. As you can see in these images, again, the left is your PAP and the right is your DIFQuick. You can see how the epithelioid cell morphology of these cells, and they occur in aggregates. They may be associated with the peripheral accumulation of the lymphocytes. Here you can see rare peripheral small lymphocytes. They may or may not be associated necrosis. If it is associated with necrosis, we call it necrotizing granulomas. If they are not associated with necrosis, we call it non-necrotizing granuloma. We have started refraining from using the term caseating necrosis because it is basically a term to describe the type of necrosis we see, and it does not hint towards any particular disease processes. That's it. Let
Okay,
me
so yep.
I want to go back and talk a little bit about the reactive conditions, which may be easily confused with the
Malignant.
malignant or atypical lesions in lung, and which often create a diagnostic challenge. In your left, you can see Crayola bodies, or which are also called as reactive bronchial cells. They usually occur in a cluster. They look very hyperchromatic, but look at how they have abundant bubbly amount of cytoplasm, not have a very prominent malignant appearing nucleoli. But whenever you are seeing a lot of these in a setup of patient under ventilator or in the setting of infection, you should always refrain from going more than atypical, especially in a limited cytology samples. To your right is a seat of benign mesothelial cells, which can be seen if you are sampling a peripheral sample of a percutaneous biopsy. Always, whenever in doubt, do a mesothelial marker along with a cytokeratin stain, especially if you're dealing with a pleural-based lesion or a pleural-based nodules. There are stains which can help you distinguish between a benign versus a malignant mesothelial cells, but by morphology, I'm not worried about malignancy in the particular picture. But the benign mesothelial cells can be highlighted with immunostains like WT1, calretinine, D240, and whenever you are suspicious of malignancy, you can add BAP1 or P16, which are lost in malignant mesothelial cells. If they are lost, then you can try doing a FISH for CDK and 2A or P16 deletion. The other things that can be easily confused with malignancy are the reactive cell hyperplasia. To your left, you can see these cells look really dark, but somewhat they have like a degenerated atypia more than the neoplastic atypia to me. So whenever you are seeing these lesions, again, refrain from calling these neoplastic. I sometimes use the term rare clusters of hyperchromatic atypical cells favor reparative atypia. That is as far as I go if I'm seeing these cells. And you can see, compare these cells with the benign appearing bronchial cells with the terminal cilia to your right as well.
Mhm.
Again, reparative changes can may be associated with necrosis, inflammation, granulomata. So whenever you are seeing necrosis along with inflammation and granulomata, my threshold of calling something malignant or suspicious is super high.
Wow, those Crayola bodies, it can really look scary. I
Yes,
can,
they can.
yeah.
They definitely can.
Okay. So let's move on to our next question. When do you usually use the term atypical then in small cytology samples?
Yeah, like I think atypia is becoming more and more of a basket term that has been
Mhm.
frequently used, right? So for me, my approach is to use the term atypical is when you see atypia, but you cannot determine the type of atypia. I mean, you cannot really say this is related to infectious, or this is related to malignancy. These are the instances where I end up using the term atypical, and that can be due to the scant sample, very less lesional cells, or that can be due to necrosis, or it could be due to reactive atypia with or without granuloma, or even in an acutely sick patient where I am favoring a reactive atypia, or in a post transplant sampling. In many instances, I have even started using the term negative for malignant cells and describe, reactive epithelioid cells favored to be reparative changes, so that I am not using the term atypical, and I'm trying to become more definitive. You will also see various degree of atypia in the squamous cells in reactive as well as infective conditions.
Mhm.
Again, if you are not suspicious of a mass lesion, the patient is on ventilator, or patient is acutely sick with infection, or a patient is a post-transplant candidate, then I use rare negative for malignant cells, rare squamous cells with atypia favored to be reactive atypia as a comment. Other where I am seeing some basal cell hyperplasia, like you see
Mhm.
in the saw in the prior image, and I'm not sure what kind of atypia is that. Then I use the term atypical, and describe rare clusters of atypical epithelioid cells to scan for definitive interpretation. If I am really suspicious about malignancy, given how the patient has a mass lesion and everything, but I don't have any sample or enough lesional cells to go there, my favorite term to use is rare clusters of atypical cells. Neoplastic process cannot be entirely excluded, so that I'm telling clinician, hey, I need a better sample for me to go beyond atypical.
To give us better samples.
Yes.
Yes, this small cytology samples can be really challenging. So just to add on that, I would like to ask another question. That is, how do you approach the cytological evaluation of different types of lung cancers in these small cytology samples?
Yes. First of all, even before going there, let me talk a little bit about atypia that you see in reactive conditions, like
Okay.
this one in the images. This was a case of aspergillosis. See
Mhm.
how these squamous cells looks really atypical,
It
but
does.
in another field, they found acute branching aspergillus
Wow.
fungi, and even the special stains proved that they were aspergillus. In these cases, whenever I see aspergillus or necrosis or granulomata, I do mention rare clusters of atypical squamous cells are seen in the background, though a neoplastic process can coexist with infective process. Atypia has been reported in infective conditions like aspergillosis as well. And I say if a clinical follow-up after adequate treatment is suggested, so that the patient still gets followed up after the aspergillosis has been treated. And this was one of the article that was published in Cancer Cytopathology in 2001, which describes the atypia seen in aspergillosis. Now let's move on to lung cancer. So broadly, in a very small cytology samples, our main aim is to distinguish whether it is non-small cell carcinoma versus small cell carcinoma. Why it is necessary to make that diagnosis? Because small cell carcinoma are associated with rapid progression, sometimes making patient sick overnight and requiring definitive clinical intervention in a very short span of time. So that is my usual approach. First, I will try to determine whether I would call any carcinoma small cell versus non-small cell. So what are the features of small cell carcinoma, right? If we are seeing clusters of small round blue cells with a lot of crossing artifact, molding, here you can see a lot of cells being molding and crossing artifact with frequent apoptotic bodies. These dot-like figures in the background are the apoptotic bodies with scant cytoplasm, and it is very cellular. That raises the suspicion of small cell carcinoma. And usually you don't even need immunostains to really call it small cell. I usually send a secure message to the clinical team if the patient is clinically sick. I give them a preliminary diagnosis. Hey, I think this is small cell carcinoma. I am going to confirm with the immunohistochemical stains and release the report as soon as I get it. Usually, it is recommended to do at least two neuroendocrine markers, either synaptophysin, chromogranin, or INSM1. CD56 alone should not be used as a neuroendocrine marker for the diagnosis of small cell carcinoma. So talking about the non-small cell carcinoma, especially the well-differentiated non-small cell carcinoma can be challenging to diagnose in a small cytology samples. Look at the image on the top of your left. This looks so bland, right? They are cellular. They have a moderate amount of cytoplasm. The cell kind of look homogeneous. There is very less pleomorphism, but the subtle clue like the presence of intranuclear inclusions or the clinical evidence of a ground glass appearance can suggest as a possibility of a well differentiated or lipidic pattern dominant adenocarcinoma. If it is a very scant sample, if I'm not confident going to malignant, I sometimes use the term suspicious for malignancy and describe the cytologic features I see. Sometimes it is quite obvious, like in the second image, you can see these cells appear so hyperchromatic. There is very scant cytoplasm, and it becomes easier to call it. Especially having a good cell block sample is often helpful in making a diagnosis of adenocarcinoma in the limited small cytology samples. Another non-small cell carcinoma, which we see very frequently, is the squamous cell carcinoma. If you're seeing highly atypical squamoid cells with keratinization in the cytoplasm, or if you're seeing a keratinous background, it is easier to go for the diagnosis of squamous cell carcinoma. However, they are often associated with necrosis, which makes the diagnosis even challenging in a minute, small cytology samples. In my clinical experience, I have found doing deeper levels very helpful to at least have some more cells to make me comfortable to call it a squamous cell carcinoma. Again, if you have lesional material available in the cell block, you can do immunostains. Squamous cell carcinoma are positive for P40. I usually try to save a lot of the cell block sample for the potential molecular analysis, and I do a very small immunohistochemical panel if at all necessary, especially in the limited cytology samples, and it is usually limited to TTF1, P40, and CK7. I do theranostic markers like PDL1 and HER2. That is our institutional protocol as well. We reflex PDL1 and HER2 in each of our malignant diagnoses. The other most commonly encountered are low-grade pulmonary neuroendocrine tumors, also known as typical or atypical carcinoid. The WHO classification, fifth edition, recommends using the term carcinoid not otherwise specified in a small cytology samples, and not to distinguish between typical and atypical carcinoid unless we are seeing clear-cut mitosis or necrosis. Then they can say then we can suggest carcinoid NOS. most likely atypical carcinoid in the limited sampling. So, what do we see in the cytology of these neuroendocrine tumors, right? They are monotonous appearing cells with a salt and pepper chromatin. You can see how they have the dotted nuclei with a salt and speckled appearance. They have prominent nuclear membrane, very scant cytoplasm, and they look very monomorphous. Sometimes they give an appearance of a spindled look, like in the image in the center. Some of the cells have spindled appearance. It is very common to see spindled carcinoid cells in long neuroendocrine tumors. In the image to the third, you can see a mitotic figure, which is highlighted by an arrow. So these are the some of the features that is helpful. I usually, I like to use the term carcinoid NOS and put everything in the comment, like the immunohistochemical stains which support the diagnosis of neuroendocrine tumor, and then no evidence, no if there is mitosis or not, or if there is necrosis or not, and what is the provisional grade. But I make sure to include a sentence that definitive grading of these neuroendocrine tumors should be deferred to a resection specimen. That is my standard statement that I like to use.
Wow, those were great elaboration on different type of carcinomas and tumors that we see in lung. I think it not only benefits the cytopathology trainees, but also all the residents and cytology students, and also in attendings, like especially in frozen section, that when we make touch prep, like these are really helpful.
Yes, yes, definitely. It is very extremely helpful. And
Yes.
more you see, I think more you become comfortable calling them.
Yes. Thank you so much, Dr. Baskota. And also, like, I think it's very important to acknowledge that the lung is a common site for metastatic malignancies that we all know often identified through FNA. Given this, how crucial is immunocytochemistry in distinguishing between different types of malignancies and also identifying metastasis in lung cytopathology?
So, to me, any long cytology sample that I get, my first intention is to be able to identify whether there is carcinoma in the or any malignancy in the specimen or not. And I do not usually reflex immunostain unless the patient has a pertinent history or imaging findings. If the patient has a history of prior malignancy, imaging findings are suspicious of a metastatic foci, then I would do the markers based on what the prior history was. Like I mentioned earlier, I try to economize my immunostains as much as possible so that I can reflex molecular, including PDL1. And recently, we have also started doing HER2 studies. But if there is no clinical history, then my two or maximum of three go-to markers would be TTF1, P40, and CK7. Do I sometime like not do full workup? Yes, of course, because for me my main preference is to have enough sample for molecular. If after reflexing molecular I think, or if the clinician reach out to me to rule out malignancy, then I do not mind doing detailed workup to reach to a diagnosis.
Okay.
That is how I
So,
approach these cases.
yeah. So, in this context, what are some of the challenges you as a cytopathologist encounter when applying immunocytochemistry in lung cytopathology?
Well, I think that is every in any cytology specimen. You see some cells in the cell block. You are
Mhm.
comfortable to call it malignant, but it turns out to be such a scant sample that the immunocytochemistry stains done in next level won't have any of the lesional cells. Then you basically base your diagnosis based on the morphologic interpretation. Another thing that we have to be very mindful is the benign elements are often intermingled with malignant elements in these scan cytology samples, like TTF1 can be highlighting the lung epithelial, CK7 can be highlighting the bronchial epithelial cells. So we have to be mindful of what we are interpreting. P40 can highlight the basal layer. of the respiratory
Mm-hmm.
epithelium. So we have to be careful not to overinterpret it and to be able to correlate what we saw in the H&E level even before going to interpret any immunocytochemistry. Other thing, like we do not really talk about the fixatives
Mm-hmm.
that we use in the cytology sample, which can also give rise to a lot of false negative immunocytochemistry stains. Specifically, I have experience with a lot of TTF1 negative adenocarcinoma in cytolized fixed cell block material. So there are many challenges that you face, and I would say always go back to H&E, look at the lesional cells before you start interpreting immunocytochemistry in any cell block sample.
So H&E is still the key, like in all other aspects of pathology.
That's definitely, and I don't think it's going to change anytime soon, Neharika.
Mhm. That sounds good. So I'm sure until now, all of our listeners are finding this super duper helpful, especially us as a trainee and residents. But one area which I haven't touched today and asked about is rapid on-site evaluation for lung lesions, which is very, very important. So when do you suggest for culture or flow cytometry or additional samples for molecular atrosa for lung lesion cytology?
So, in the beginning of our podcast, also I mentioned if I am seeing any amount of atypical lymphoid
Mhm.
cells, whether they are even if it is a very low grade but monotonous appearing lymphoid cells, I do not hesitate to tell the clinician, hey, we need an additional sample for a dedicated flow. Can I get a dedicated sample for RPMI? Sometimes, small cell carcinoma can easily be confused with diffuse large B cell lymphoma. In those instances, I have even asked to my technician to save the RPMI sample in the freeze until I get the cell block next day, so that I can decide whether I really need to send that flow or not. And
Mm.
even if you send the flow, a small cell carcinoma can be CD56 positive by flow and often can help you make the diagnosis. Other, if I see necrosis or inflammation or granulomata, though necrosis or even granuloma or inflammatory cells can be seen both in neoplastic or non-neoplastic conditions, I do not hesitate to tell the clinician, hey, can we send for culture? Can we say, does the patient has any history of mycobacterial infection, any exposure, any travel? Why don't we send for even fungal and AFB culture? I have a very low threshold of telling them to send anything for culture. If I am confident that we are seeing a malignancy in a lung lesion at rapid on-site evaluation, I tell them, hey, I need four more passes so that I have enough for patient molecular studies. And often clinicians abide by us, because they know
Yeah,
we are going to ask for more. So
more.
I think clear communication is the key to go, and to asking for more is never going to hurt.
Okay. Yeah, actually, my next question was related to that because communication is the key. Like, it's really important in our, not only in our, I think, in overall clinical settings, the communication between multidisciplinary team is really important. So, how do you navigate communication and collaboration between cytopathologists, clinicians, and also radiologists in the context of long lesion diagnosis?
So, this is what I say to everyone, including my trainee: say what you see. Nothing more, nothing less. Imaging can guide you, clinical history can, of course, guide you, but you're a pathologist, so you say what you see. If it is a very scant sample, if there are rare cells, I tell them, hey, these are very rare cells, but I see the patient has a history of blah, 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 blah. I won't be able to tell you if this is epithelial versus mesenchymal versus
Mhm.
lymphoid. I need a better sample. You know,
Yeah.
if I all I see is necrosis, hey, the most I can go is atypical because all I see is necrosis. It could be a high grade malignancy, or it could well be a inflammatory process or an infective process. I need a better sample. I think one thing I would definitely say to all the trainees and even to new in practice pathologists is you learn a lot by even attending the tumor board, if not presenting at the tumor board, because it's a very constructive discussion, which is often multidisciplinary. Especially in these challenging cases where I had a scanned biopsy sample and the clinician were asking, hey, does it help if I go back and take more tissue? Whatever I wrote, how much detailed I wrote in the report
Mhm.
is very valuable of how I communicate to the clinician. So I think the biggest comment I put in any case is in the atypical category, and I make sure to read that comment before giving a call to any clinician, or whether I'm talking to a radiologist or an oncologist.
Totally agree. I think tumor board is a great platform to learn everything, like how to communicate between clinicians, the clinical team, and you learned so much from the tumor board.
Right. Yes. I cannot agree more.
Also, in my short experience as a pathology resident, I have seen different practices related to cytology and small biopsy samples service designation. So, in your practice, Dr. Baskota, do you also look at long biopsies or does it get turfed to surgical pathology services?
So this is how we approach these cases. If we have a concurrent lung biopsy with a cytology related sample, whether it is a lavas or EBUS, FNA for staging of the lymph nodes, these gets into assigned into cytology services. If we only have a small core biopsy without any cytology sample, then it get assigned as a surgical biopsy specimen. But in my current practice, since I sign out both cytology and breast and lung surgical pathology,
Mhm.
I often get to see the both.
Wow, great. So,
So what?
like,
How do they practice at your institution,
yeah,
Erica?
so in my institution, the current practice is it gets turfed to surgical pathology services.
I see. I have seen that adopted in many other institutions as well.
Yeah, but at the end, you always make correlation between the both, looking at the
Yes,
history. So,
yes. In
yeah.
my prior practice in New York, most of the lung biopsy samples were accessioned to the surgical pathology services, and I remember I used to go and look at the
Yes,
surgical biopsy sample before I sign out any case.
cases. That's how we do it here as well.
Mhm.
So, like, I'm really enjoying this conversation with you. It's such an insightful talk, but due to time constraint, I would like to say now that my next question would be the last question to you. So, lastly, is there any widely adopted classification system that we should be aware of while reporting long cytology?
So, like WHO has started standardizing all the reporting for any cytopathology specimen. They have come out with pancreaticobiliary cytology classification, and they have also come out with reporting of lung cytopathology. They have put forth 5 diagnostic categories: insufficient, inadequate, or non-diagnostic is the first. Second is the benign or negative for malignancy. Third is atypical. Fourth is suspicious for malignancy, and fifth is malignant. They have also estimated risk of malignancy for each of these 5 diagnostic categories and also put forth the clinical management options. You can easily find this classification system online with the WHO online access as a part of the online access, or even they have issued a paper book for reporting lung cytopathology. I often find helpful using these categories. Honestly, even before devising of these categories, we were loosely using it, but having a standardized reporting system is always helpful and welcome inside a pathology practice.
Indeed. Wow, that's great to know. So, here we come to an end with my questions. I hope all our listeners really enjoyed because this was a great, insightful session, I would say. Thank you so much, Dr. Baskota, for sharing your expertise and insights on long cytopathology. It's really been a pleasure having you on the podcast today. And also
Thank
to
you,
our
Neharika.
Yes, and also to our listeners, thank you for tuning in into today's episode of Cytopathology Podcast. Stay tuned for more insightful discussions in the world of cytopathology. Have a good night. Bye bye.
Bye. Bye, everyone. Thank you so much.